safe, as safe as possible. So with those comments, that brings us to today's session, the main portion of today's session on myth busting. So our main objective for today is to identify and correct common misconceptions associated with both PPE use and selection in COVID-19. And we're going to do this by having two experts from Public Health Ontario debunk some of the common myths in PPE use and help us to apply best practices to make better choices with respect to PPE. So it's my pleasure to introduce Devin Metcalf and Casey Gambetta. Devin and Casey are both regional infection prevention and control specialists with Public Health Ontario. Devin holds a master's and a PhD in microbiology from the University of Guelph. She's also certified in infection control, and Casey holds a bachelor's in nursing from Queen's University, a master's in nursing from the University of Toronto, and she's currently working towards her PhD at the University of Guelph, and she's certified in infection prevention and control. So in a moment, I'm going to hand the floor over to both Casey and Devin, but I just wanted to remind folks as questions come up to make sure you're inputting them into the Q&A function, because that's where we're pulling all of the questions from in the moderated Q&A that follows the presentation. Okay, Casey and Devin, over to you.
Okay, thank you. So I just want to confirm everyone can see my screen. Okay, great. So thank you very much for having us today. Casey and I are excited to be here to talk to you about some PPE myths related to COVID-19. So the information we have for you is accurate as of today. So keep an eye out for changes in directives or new guidance, because the guidance may change as we learn more. And we will be talking about best practice recommendations today, but there may be public health leadership in your area that, in consideration of your local context, may be recommending something a bit more stringent. So we would always recommend following the advice of your local public health unit. So please don't try to read this slide. This is just a notice from us stating that although our work is guided by current best practice, best available evidence, we don't develop any policies or directives issued by the Chief Medical Officer of Health. So please refer to Directive 5, which is the prevailing directive for the provision of PPE. And just a quick comment about Public Health Ontario, who we are and what we do. We are a provincial government agency, and our mandate is to provide scientific and technical advice to support all of our stakeholders, and they include people working in government, public health, healthcare, and related sectors, so all of you. And recognizing that these are very challenging times, there are a lot of supports available to those working in healthcare. So your local public health unit is a great support for responding to infection control issues, outbreak support, and case and contact follow-up. At Public Health Ontario, we are available to respond to any questions you may have regarding best practices related to infection prevention and control, and for scientific advice, so you can email us anytime. The Ministry of Health provides a lot of guidance for healthcare sectors, and of course, Ontario Health is available and is very active in the supports that they offer. So we have a few objectives for today. The first objective is to identify and discuss some common misconceptions in regards to personal protective equipment use. So these are the myths. And then we will highlight some of the PPE best practices and resources as we talk about proper PPE selection and use. So these will be the truths. And finally, provide an opportunity at the end for you to ask some questions. So we decided today to look at some common myths related to PPE because there is a lot of information out there, and it sometimes changes, and it can be difficult to figure out what best practice is and what you should and shouldn't be doing related to PPE. And we organized our presentation today by types of PPE. So to start, Casey and I will address myths related to masks and mask use. So the first myth we'll be talking about today is related to the use of 2 masks at once, and the idea that wearing 2 masks will provide better protection than just one. So although it may seem intuitive that 2 masks offer better protection than just one, as of right now, there is no evidence that wearing 2 medical masks, so a procedure or a surgical mask, offer better protection. And wearing 2 masks can be problematic. So those extra layers may make it harder to breathe and may be less comfortable, resulting in an increased risk of touching or readjusting your mask, risking self-contamination. And you want to ensure that your medical mask is comfortable and fits securely over the nose and mouth, so you don't have to adjust it. So if you do need to touch your mask while wearing it for any reason, you want to ensure you are doing so with clean hands, so perform hand hygiene before and after touching the mask. And we have included here a link to an infographic created by Public Health Ontario that outlines the steps for putting on and taking off personal protective equipment, and there are some nice details on the proper technique for putting on and taking off a mask. Okay, I'll turn it over to Casey for the next myth.
Great, thanks, Devin. So our next myth is, if I work in a healthcare setting but don't see patients, I can wear a cloth mask. Slide. So the truth is that most of those who work in healthcare settings must wear medical masks. Healthcare providers must wear medical masks at their facility if they have direct contact with patients, they work within clinical areas where patients are seen, or if they have contact with other healthcare workers who may have contact with patients. If a healthcare worker does not meet any of these criteria, a cloth or homemade mask may be considered. If cloth masks are worn in a healthcare setting, all staff must be wearing masks at all times. Slide. All right, so there's many reasons that cloth masks are not a consideration for the majority of healthcare workers. Some of these factors include they're for source control only and not considered to be PPE to protect the healthcare worker from potentially contagious patients or other staff members. And as we know, people can be contagious before they're symptomatic, so we want to be careful. They're not tested to recognize Health Canada standards to assure appropriate protection. The fabrics are not the same as those used in medical masks, which have been shown to meet standards such as material integrity and particle resistance. And the edges are not always designed to form a seal, and therefore they may leave large gaps around them that do not provide complete protection against virus-sized particles. So due to these factors, strong consideration should be given to the use of medical masks for all those who work within healthcare facilities.
Okay, so the next myth is the more layers in my mask, the better. So the truth is the more important consideration is to ensure medical masks are approved by Health Canada for use in healthcare. So when it comes to medical masks, you want to ensure that what you are using has been approved, as those masks have been tested against standards and are effective in protecting against COVID-19. And these medical masks typically do consist of at least 3 layers. If we're talking about non-medical masks, so those would be the fabric masks that are worn as source control and not PPE, and source control meaning a mask that would protect others from the wearer, they do not go through approval process for medical masks by Health Canada. And they may offer different levels of source control depending on how they are constructed, and these may be made of 2 or 3 layers. 3-layer non-medical masks have a theoretical benefit over a 2-layer mask and may be recommended by some public health professionals, but the benefit hasn't been clearly proven. So currently there aren't any great studies that compare the effectiveness of a 3-layer versus a 2-layer mask when it comes to transmission of the virus that causes COVID-19. As I mentioned in the previous slide, there is a theoretical benefit of a non-medical mask having 3 layers versus 2, particularly if the middle layer is a filter. So the filter may increase the effectiveness of the mask, but it may also reduce breathability or be inefficient if there is a poor fit. And the main consideration when it comes to wearing non-medical masks is the consistent and appropriate use of one. So when you are unable to physically distance from one another and in shared indoor spaces. So there is no need to discard your 2-layer masks. They are fine to continue to wear. And the next slide will outline some key considerations for wearing non-medical masks. So regardless of whether it's a 3-layer or a 2-layer non-medical mask, it should fit properly. So completely covering the nose, mouth, and chin without any gaping. It should allow for easy breathing, so consider the material it's made out of. It should not contain an exhalation valve, which would make it ineffective as source control, and it should fit securely on the head. It should be comfortable, so it could be worn for a while without feeling the need to adjust it. It should also maintain its shape after being washed and dried. And as you should check the mask after washing and drying to ensure that it's still holding together properly and does indeed hold its shape. It's also important to remember that non-medical masks are source control, so they protect others from the wearer. They're not considered personal protective equipment and they are not Health Canada approved. And the innermost layer, so the layer that would have contact with the skin, should be a cotton or cotton blend material, something that isn't likely to irritate the skin. All layers should be washable, or in the case of a 3-layer mask, any part that can't be washable, such as the middle filter, layer should be disposable. And one other consideration with respect to non-medical masks, given the weather this time of year, you may notice that your mask will get wet if worn outside. So that's just an indication for it to be changed. So you may find that you need to have access to more masks to ensure you always have a dry one on hand.
All right, so the next myth, I need the highest level of medical mask when caring for someone with COVID-19. So at this time, I'm actually going to bring up a poll to allow you guys to test your knowledge quickly before we discuss this myth. Ooh, look at those moving. All right, so we have a lot of responses actually, and it's quite mixed. So I'm going to end that so it's not in the middle of your screen, but it looks like most have chosen a level 3 mask for this. Okay. All right, let's move on and discuss this myth a little bit. Okay, so the truth is that a level 1 mask is actually usually appropriate. So Health Canada refers to the American Society of Testing and Materials, ASTM standards for mask classification. And this is a US organization that develops and publishes voluntary consensus technical standards for a wide range of products. So the 3 mask classifications under the ASTM are based on their fluid resistance or ability to prevent fluid penetration, and not necessarily their capacity to stop droplet transmission. So level 1 masks are effective against venous pressure splash. And so they are considered a low level barrier protection for general use for low risk non-surgical procedures and exams that do not involve aerosol sprays and fluids. Level 2 masks are effective against arterial pressure splash, and they are considered to be a moderate barrier protection for low to moderate levels of aerosol sprays and fluids. And finally, your level 3 masks are effective against really high velocity procedures, and they're considered maximum barrier protection. And this is for situations where there's a potential for heavy levels of aerosol sprays and fluids, such as your traumas or cardiovascular surgery. So determine which mask level you need. You want to conduct your point of care risk assessment before every interaction with the patient or resident. And as you know, COVID-19 is spread through droplet and contact precautions, which would not create high pressure sprays. And therefore, the use of a level 1 mask is appropriate for standard care for someone on droplet and contact precautions. Now, if you do your point of care risk assessment and you determine that you will be performing a higher risk procedure where there could be potential for blood or body fluid sprays, such as open tracheal suctioning on a patient, you may then consider at that point to use a higher level mask, such as a level 2 mask. But for your standard care for someone on droplet and contact precautions, such as COVID-19, you can use a level 1 mask.
Okay, so the next myth relates to the use of N95 respirators. So the myth is that we need to wear N95 respirators when caring for patients, residents, or clients with COVID-19. So hopefully after Casey's explanation on the previous slide, you already see why this is a myth, but I actually have a polling question as well. Okay, hopefully everyone can see that. So the question is, when should you wear an N95 respirator? The options are all the time, during an aerosol generating medical procedure, to provide routine care for a patient, resident, or client, or unsure as an option. So I'll give everyone just a moment to answer that. Okay, majority have answered. Definitely one answer is favored. So I'll just share the results there. So yes, most of you are correct. The most correct answer is during an aerosol generating medical procedure. So that's the most common indication to wear a fit tested N95 respirator. So we'll talk about that a bit more on the next slide. Okay, so the truth is that a medical mask is protective against the virus that causes COVID-19, and there would only be certain exceptions for when an N95 respirator is indicated. So this virus is transmitted primarily by droplets during close, unprotected contact. So anything within 2 meters. There may be a role of other modes of transmission, such as through contact with contaminated surfaces, but really that close, unprotected contact is thought to be the most significant way the virus is transmitted. So based on current evidence, the use of medical masks along with other appropriate personal protective equipment accompanied with proper hand hygiene practices is protective against transmission. So there are exceptions, however, to when you wouldn't use a mask, and those would be during aerosol generating medical procedures such as BiPAP or high flow nasal cannula therapy. There is a potential during these procedures that very small aerosols may be generated that could be disseminated over a larger distance and remain suspended in air a bit longer than a typical droplet. So while in the room when an aerosol generating medical procedure is occurring, N95 respirators should replace the medical mask and be worn with other indicated PPE.
Okay, so our next myth, it doesn't hurt to wear an N95 respirator even if it is not required. Okay, so in truth, wearing an N95 respirator when it is not necessary may actually increase risks. So risks of wearing an N95 respirator when it's not necessary can happen in several ways. So N95 respirators are typically a less comfortable respirator, less comfortable mask, and they're more challenging to breathe through than with your standard medical mask. As it's typically less comfortable, extended use may increase the risk of needing to touch it or adjust it, increasing the risk for or potential for self-contamination. There's also an increased risk of self-contamination during the removal, as it can sometimes be more difficult to remove than your medical mask. And finally, N95 respirator use may also create a false sense of security of staff, leading to more lax IPAC practices and not wearing other necessary PPE or changing PPE when it really is required. Next slide, Devin, please. And these are just a few resources actually that you can have a peek at later on.
Okay, similar to the last myth that I discussed, as there has been a lot of discussion around aerosol transmission of the virus that causes COVID-19, our next myth is that COVID-19 is spread through aerosols, so we need to wear an N95 respirator all the time. So the truth is that transmission of the virus that causes COVID-19 is predominantly through close, unprotected contact with an infectious individual. Aerosol transmission may potentially opportunistically occur with a prolonged exposure in avoidable settings such as closed, cramped, and crowded spaces. The use of PPE to prevent transmission shouldn't be the only consideration, but there should also be attempts to improve or prevent conditions that could potentially facilitate the accumulation of aerosols in large enough quantities where aerosol transmission could occur. So some strategies may be to reduce the use of cramped closed space for care activities, avoiding crowding, and improving ventilation when possible. And importantly, as outlined in ministry directives, point of care risk assessment and your clinical and professional judgment is to be used to determine what precautions you need.
All right, so our next myth, all N95 respirators provide the same protection. Slide. So in truth, all respirators must meet Health Canada criteria for use in healthcare settings, and they do not all provide the same protection. So respirators traditionally used in Canada meet NIOSH standards, and NIOSH is the US National Institute of Occupational Safety and Health, and it's responsible for setting standards in the US related to occupational safety and health and the certification of these products against those standards. So N95 respirators, as you guys know, are recommended for aerosol generating medical procedures. They must meet particular filtration standards to be approved for use in Canada and in Canadian healthcare facilities. And the N in N95 actually stands for not oil resistant, which isn't overly relevant in healthcare. And the 95 means that these respirators are able to filter up to 95% of particles from the air. Slide. So you may also come across KN95 respirators when you're trying to find approved respirators for use, particularly during the supply shortages. So KN95 respirators are certified based on regulatory standards in China, and they may have similar properties to N95 respirators. However, not all respirators have been found to filter to the same recognized standards as N95 respirators that are traditionally approved for use in Canada. So Health Canada has actually added many more respirators, including some of these KN95 respirators, to their list of approved medical devices for use during COVID-19. So you'll want to be sure to check your PPE on the Health Canada website on this list prior to use in your healthcare setting. Other types of respirators that you may have come across are EN, I think they're out of Europe, KMOEL out of Korea, and then ASNZ, so Australia and New Zealand models. And they all stem from different regions of the world. And like other respirators, some would meet our standards, some would not. So you want to confirm that they are approved by Health Canada on their website. I think Devin mentioned this, but regardless of the type of respirator, staff must always be fit tested for a respirator to ensure that it meets the necessary level of filter efficiency. So if you're not fit tested, it doesn't necessarily meet that 95% filter efficiency that we're looking for in N95 respirators.
Okay, so now we'll talk a bit about the universal use of PPE. So simply put, that means wearing PPE all the time. So the myth is that I should wear full PPE at all times. And we do have one final polling question here. Okay, hopefully everyone can see that. So as we know, this is a myth. What would be the correct answer to the question of what PPE should be worn at all times? So your options are a non-medical mask, a medical mask, an N95 respirator, gloves, or unsure. Give everyone a moment just to complete that. Okay, responses are slowing down, so I'll just close that poll, share the results. Okay, so of this list, the only thing you would be wearing all the time, so regardless of your activities, would be something for source control, which most of you said. So protecting others from the wear, and it may depend on your setting. So if your workplace is not a healthcare setting, a non-medical mask for source control to align with existing guidance and your policies may be fine. But non-medical masks aren't considered PPE, so generally not appropriate for healthcare. So we've already discussed that N95 respirators are most often indicated for use during aerosol generating medical procedures, and overuse of gloves has contributed to increased transmission of microorganisms and decreased compliance with hand hygiene. So the answer is not gloves. So depending on your setting, the most correct answer would be a medical mask. You will typically find healthcare settings require healthcare workers to wear medical masks at all times, which can function as both source control and PPE when used with other equipment such as eye protection. Okay, so the truth is universal use of full PPE is not recommended. So healthcare facilities will typically have universal masking policies and are instructed to adhere to physical distancing measures. And when followed, the risk of transmission from staff who have the virus but have no symptoms is minimized. So we've linked here two resources. One is a fact sheet on how to self-isolate in the event of an exposure or if you are symptomatic, and the other is a fact sheet on physical distancing with strategies around how to maintain physical distancing when outside of your home and some key things to avoid. So overuse of PPE may diminish supplies, which can lead to critical shortages, and may also create lax IPAC practices. So it seems as though the more people use personal protective equipment, there is an increased risk that they become less careful with important practices such as putting it on or taking it off. And the last resource linked in this slide is a fact sheet on universal mask use in healthcare, which includes some guiding principles and tips for extended use or reuse of masks.
Okay, so our next myth is we commonly encounter is the belief that due to PPE shortages, we should try to wear a PPE for as long as possible. So in truth, PPE should be changed following every patient, resident, or client interaction. There are a small number of exceptions that I'll speak to. So there are a few considerations for extended use of PPE, which may be implemented during critical supply shortages, which we have come across at points during this pandemic. So gloves must be changed when the task they were needed for is complete, when moving from a contaminated body site to a clean body site, if a tear or hole in the glove is detected, and when moving to provide care to a different patient or client or resident. So that's pretty typical standard IPAC principles. Gowns must be changed when you are no longer providing care to a patient. You are moving on to provide care to a different patient. In these cases, the gown should be removed at a doffing station set up just inside the patient's doorway. Gowns must also be changed when leaving a cohort of confirmed COVID-19 patients. This may include if you're moving on from a cohort of positive patients to a non-positive patient or to complete administrative activities. Extended use within a COVID-19 positive cohort is actually the only circumstance where extended use of gowns may be considered. You should also change your gown if it becomes heavily contaminated. So gowns and gloves should never be worn in hallways, utility rooms, or administrative areas such as nursing stations or charting rooms. It is important to remove them at the point of care, just inside the patient's room, to ensure that areas outside of the room are not contaminated. Slide. Okay, so eye protection. Eye protection must be changed or cleaned and disinfected following interaction with the patient on droplet and contact precautions or upon exit from a COVID-19 positive cohort, when it is visibly soiled or difficult to see through, or if it is being removed for later use. At this time, strong consideration should be given to cleaning and disinfecting eye protection between each patient during COVID-19 if your facility is following a universal eye protection protocol where staff are wearing their eye protection for the entire shift. So moving on to medical masks. So medical masks must be changed when it becomes damaged, wet, or difficult to breathe through. It becomes contaminated. Your mask should also be changed if you are no longer providing care to a patient who's in additional precautions, or again, when you are leaving a COVID-19 positive cohort. So you may have noted that discarding PPE following an interaction with a patient on additional precautions or when leaving a COVID-19 positive cohort is required for all PPE types. And I know that's a lot of information, so I think you might have been notified we will be sharing this information after, so you don't have to scramble to write that down either. And these are just a couple of resources as well that you can refer to for more information on PPE use for COVID-19.
Okay, so next we'll talk about some myths related to isolation gowns. So the next myth is about reusing or extending the use of a gown. So I can reuse a gown or share a gown with a colleague if we are caring for the same patient, resident, or client. So the truth is reusing gowns is not recommended. Ideally, they are used once and disposed of or laundered if they are reusable. So we have been asked about and have observed the practice of gowns being hung outside of a room for later use by staff member for their next interaction with the individual. This is not best practice as it creates a potential risk of contaminating oneself when putting the gown back on or contaminating somebody else who may brush up against the gown. So there are very limited circumstances when a gown can be used for an extended amount of time. So for example, as Casey explained earlier, when caring for more than one COVID-19 positive patient or resident who is cohorted. So if there are rooms that are located close together and you're providing care to one individual right after another, and these are confirmed cases, there may be an opportunity to keep that same gown on, but again, only during supply shortages. A gown, however, should never be taken off and used again at a later time. So once the gown comes off, it should be immediately placed in a garbage bin or a laundry hamper, and this should occur just inside of the patient or resident room or examination room prior to exiting. So we have linked to a fact sheet on this slide as well on medical isolation gown use in healthcare, which outlines the purpose of how to use gowns and some strategies for conserving the supply.
Okay, our next myth. I need to wear a high-level gown when caring for a patient with COVID-19. So the truth is that like mask, a level 1 gown is sufficient for routine care of a patient with COVID-19. So similar to other PPE, gowns must be approved by Health Canada to ensure they meet minimum standards for use in healthcare settings. Prior to each interaction with a patient, it is important to identify the desired level of protection based on potential exposure to blood and body fluids during the activity. And this is known as your personal risk assessment or your point of care risk assessment. So gowns are classified by levels 1 to 4 based on fluid resistance, with level 4 gowns having the most resistance. Higher levels of gowns like 3 and 4 are used for procedures where high levels of splashing or spraying may occur. So this is during such things as cardiovascular surgery or trauma procedures. A level 1 gown provides sufficient protection against droplets and therefore is appropriate for routine care of a patient on droplet and contact precautions such as COVID-19. You can also check out the resource that we've linked here, which I think Devin actually was the same one Devin spoke to as well. And it actually has a chart that identifies each level of gown and the typical uses for each gown.
Okay, so now we'll focus on eye protection. So the next myth is prescription eyewear can be used as eye protection. So prescription glasses are adequate to protect my eyes from the virus that causes COVID-19. So the truth is no, prescription eyewear is not an acceptable form of eye protection. So eye protection is defined as a device that covers the eyes from all sides and is used by healthcare providers under certain circumstances. So first, when it is anticipated that a care activity is likely to generate splashes or sprays of blood or body fluids, or within 2 meters of a coughing, sneezing, a client, patient, or resident, or when interacting with someone on droplet and contact precautions. So the Provincial Infectious Disease Advisory Committee lists 4 types of eye protection: safety glasses, safety goggles, face shields, and visors that come attached to the medical masks, but prescription eyewear does not sufficiently cover the eyes to be considered PPE.
Our next myth is that I can wear eye protection all day and only need to clean it if I remove it for breaks. So this is a very common question or myth that we see. And so there's going to be quite a bit of information thrown at you over the next few slides. But again, we're sharing this slide, so don't worry too much about taking notes as we go. Okay, so the truth is that reuse or extended use is not best practice and should only be implemented in times of shortages. There are many considerations that must be taken if reuse or extended use of eye protection is being implemented at your healthcare facility. And these include, it must be dedicated to a single healthcare worker, as there are typically non-cleanable parts and no manufacturer's instructions for cleaning. If universal eye protection has been implemented at your facility, consideration should be given to cleaning between each patient interaction during times of COVID-19. This will help reduce the risk of transmission via the eye protection. This is also consistent with IPAC principles of not reusing PPE between patients. Regardless, eye protection must always be cleaned and disinfected following an interaction with the patient on droplet and contact precautions, and when care is completed within a positive cohort, so a group of COVID-19 positive cases, and when you're leaving that cohort. This is consistent also with when you would change your mask. You must also clean and disinfect your eye protection when it is visibly soiled or when you are removing it to store for later use. You must dispose of your single-use eye protection if any of the non-cleanable parts, so the foam or the straps, becomes visibly soiled. Slide. So cleaning and disinfection of eye protection may be done by the healthcare worker at a dedicated station. This station should be as close to the point of care as possible, such as at the doffing station just inside the patient's room. And staff should receive training and education to assure they can remove, clean, and disinfect the eye protection in a manner that minimizes risk of contamination to the staff member or to the surfaces around them. A cleaning process and setup should be in place to ensure proper cleaning and disinfection of the eye protection occurs. So there should be a standard process in place that all staff are aware of and they're able to follow. And I'm just going to run through a potential process for you here. So a potential process could include the following steps. Place a designated cleaning surface at each doffing station. If there is insufficient room at the PPE doffing station, a designated cleaning station may be set up in a safe place nearby. Following the interaction with a patient, the healthcare worker can proceed to the station, remove and dispose of their gloves and gown using the safe removal technique, followed by hand hygiene. They then put on a clean pair of gloves and place a clean paper towel down on the surface. They can then remove their eye protection using the straps only and place it on the clean paper towel. They would then proceed to clean the eye protection with an approved cleaner disinfectant wipe, starting on the inside of the eye protection, which is considered the less contaminated area, and moving to the outside. And this is similar to environmental cleaning principles of moving from the clean to the dirty part of the eye protection. So using a second wipe, disinfect the eye protection, again, starting on the inside and moving to the outside. You also may have 2-in-1 cleaning and disinfection wipes. And in that case, you may only need to use one wipe if that's what the manufacturer recommends. You then need to allow the eye protection to fully air dry, ensuring it remains wet for the recommended contact time of the disinfected product. Following this, you can remove your gloves and discard and clean your hands. And then clean and disinfect that surface, that cleaning station surface, so that it is clean for the next person to use. Single-use eye protection would ideally be disposed of at the end of the shift and not saved for the next day. And for reusable eye protection, ideally it can be placed in a closed container to be processed by a central processing department. And this would be following the manufacturer's instructions that would come with reusable eye protection. Slide. Okay, so if you are storing your eye protection for reuse at a later time, it must be stored in a manner to prevent contamination and labeled to avoid being used by another healthcare worker. And I'm sure this has been ingrained in you guys by now, but an example would be placing it in a papered bag with your name on it. The number of times that disposable eye protection or single-use eye protection can be reprocessed is really unknown. And therefore, eye protection should be closely examined prior to each reuse to ensure the integrity of it, or the integrity of the foam pad, the elastic strap, and as well as the clarity of the visor, because sometimes those disinfectant wipes can break down the visor and make it more difficult to see through.
Okay, and the final pieces of PPE we will talk about today are gloves. So the first myth on the topic of gloves is that applying alcohol-based hand rub to gloves is an effective practice. So the truth is, using alcohol-based hand rub on gloves is not best practice, and it has been shown to be detrimental to the integrity of the gloves. So it can actually damage the gloves and make them less likely to fully protect you. One concern is that it can provide a false sense of protection, as organisms may remain present on the gloves after application of the hand rub. Historically, ABHR is tested on skin, not glove material, and using it on something other than skin will likely go against the manufacturer's instructions for use, which typically instructs the user to apply it directly to the hands. So applying ABHR over gloves wouldn't count as performing proper hand hygiene. And if it's damaging to the glove material, it may create an opening for microorganisms to pass through. So removal of gloves using a safe removal technique and hand hygiene between every patient, resident, or client is considered best practice. And just a reminder that the 4 moments for hand hygiene are before contact with a patient, resident, or client or their environment, after contact, before an aseptic procedure, and after risk of exposure to blood and body fluids.
Okay, so our final myth for you guys today is that double gloving provides me with extra protection. So the truth is that double gloving is typically not recommended. Double gloving can lead to discomfort and increased manipulation, and this increases the risk of self-contamination as well as leading to potential misses in those really essential hand hygiene moments. So as you guys are aware, hand hygiene is one of the most important principles of infection control, and we don't want to replace our hand hygiene by wearing an extra set of gloves. So gloves are not perfect, and they also might have small micro tears, and therefore they're not completely effective at preventing the contamination of your hand, but also the second layer of gloves underneath your hand. So So removal of gloves using the same removal technique is also more challenging, having that second layer, and that can increase the risk of self-contamination upon removal. So really wearing a single pair of gloves, removing and disposing of them using the safe removal technique, and conducting hand hygiene between each patient interaction is best practice. All right, so we have come to the end of our Mythbusters session today, and thank you guys so much for hanging in there with us. We're now going to turn to the Q&A portion, and I just want to introduce, along with Devin and I, Dr. Kevin Schwartz, an IPAC physician from Public Health Ontario, is on the line with us to help answer some of your questions. I'll just make a quick comment, and someone will probably speak more to this, but the questions are going to be pulled from the Q&A box. And we're going to focus on the PPE related questions as much as possible for this session to ensure that we answer as many of these as we can, because that's what this session is focused on. We're also going to try to focus on those questions that are most relevant to all attendees. If you have very specific or IPAC questions very specific to your own facility or region, we encourage you to reach out to your local public health unit for more guidance, because they can provide a lot more facility or region specific guidance. All right.
Awesome. Thank you so much, Devin and Casey. That was incredible and lots of really good information. Before I hand the floor over to Kathleen to get us started on the Q&As, I just wanted to assure everyone that we will make an effort to get this information out as soon as possible, hopefully this week, because there's lots of really great resources in these slides. And over to you, Kathleen.
Thank you very much. That was an excellent overview and presentation. So we've gotten lots of questions, and I remind all participants that you can vote to move questions up in terms of order of answering. And as Casey and Devin have just explained, they're going to try to focus on some that are higher level so that they'll be most applicable to all attendees. The first question we have is in the context of home and community PSWs, and there are a couple of questions there. So one is about the frontline staff. So can you reconfirm that the home and community sector is not required to supply their frontline staff with N95 masks, as they do not perform AGMPs? And I'm not sure which of our panelists or whether Susan Gibb might like to provide an answer.
Hello, everybody again. So when we talk about providing N95s, there's two separate pieces I want to address. One is, when is an N95 required for the protection against COVID? And that is when performing AGMPs. When an organization provides N95s as a resource for their staff, depends on the organization and the direction they receive from local public health or other local direction they receive. So for the protection of COVID, an N95 is recommended when performing an AGMP. I want to be clear about that. Some organizations are covered under Directive 5 for having N95s available when a provider makes an at-a-point risk assessment. Then Directive 5 is covered, and they need to have an N95 available when the provider makes that risk assessment. But that does not cover everybody in all situations. I hope that makes it a bit clearer. Anything to add from public health?
Casey or Devin, nothing to add to that? Okay, great. The second part of the same question, again in the context of home and community PSWs, question around nitrile gloves versus vinyl gloves and when they should be used. So the questioner asks about having pushback from staff demanding we only supply them with nitrile gloves when they are offering education to reassure them that nitrile gloves versus vinyl gloves do not provide extra prevention against COVID. Would someone like to comment on that?
I would actually just refer everyone to the Provincial Infectious Disease Advisory Committee has their routine practices and additional precautions document that actually has a really nice chart kind of outlining all the advantages and disadvantages to the different glove types. And we'll specifically kind of compare vinyl and nitrile and just indicating, you know, what they are specifically good for. And so they kind of indicate that vinyl is as ideal for minimal exposure to blood and body fluids, and nitrile is for a slightly heavier exposure. But I'd refer everyone to that chart actually to kind of sort of compare and see which ones would be the best option.
Okay, great. Thank you, Devin. A question about a recommendation regarding the expired N95. Should they be kept in storage or should they be gotten rid of?
So there is the ministry has allowed some flexibility with the use of expired N95 masks. The important thing is that people can still be fit tested to them, and that other pieces like the straps or the nose piece are still intact, and so they're still working properly. I wouldn't I wouldn't recommend using them over non-expired ones, but if that is the last resort, keep them on hand just in case. Another option is you can use N90 expired. You can often use N95 respirators that have been expired as medical masks as well.
Okay, very good. Thank you, Casey. Question about the Brockville plant. Where does community support fall into the line for N95s? This person is saying they have clients that use HEMPs, and I think Susan Gibb, you might be the person to address that.
Thank you, Kathleen. So when it comes to the product that will be coming out of the Brockville plant, we don't have access to that information. What I do know is product that does come from that plant, if it comes into the pandemic warehouse, we will then continue to support organizations with accessing N95s through our processes. I think if you have specific questions, we do not disseminate N95s by sector. We disseminate them based on whether or not AGMPs are being performed and whether you're enacting Directive 5. So it really would be a question to ask your procurement people if they have reached out to the plant and through their own supply chain about what are the chances of being in line for those products. But it really comes through procurement. If you have additional questions, please contact me directly and I can get you in touch with some people.
Okay, thank you very much, Susan. And I just remind all the participants that all questions will be answered after this meeting, so there will be a full Q&A list available. This person is asking about upping the production of N95s, and they're wondering if that is in anticipation of a shift from surgical/procedure masks to N95s in a variety of community settings, or will this continue to be recommended only for aerosol generating medical procedures? I don't know whether Devin or Casey have anything to say about that.
As far as we know at this point, best practice for COVID-19 is still the use of medical masks except for aerosol generating medical procedures.
Okay.
Kathleen, if you don't mind, I will add to that. When people are hearing in the media or in our presentation about ramping up the production of N95s, it is because since the beginning of this global pandemic, we have had a constraint on N95s that we have been able to import into the country. And that is for lots of various reasons, but specifically the majority of our N95s come out of a 3M plant in the United States, and it was the United States itself that limited the volume that could be exported outside of the US. So this is us taking care of us and getting N95s produced domestically. So you will hear it. It has nothing to do with the need that we are going to need an N95 for day-to-day care in care settings. I want to be very clear about that. Thank you.
New question about the use of wipes. Would home and community care be a priority group for use of wipes? The questioner is saying they don't have the means to deal with cloths, for example, laundering and distribution. If home and community care staff are to use the spray, will instructions on how this can be safely implemented be provided to the regions?
We can't answer that from a PHO perspective, but are our earlier speakers still on? Because they might be able to speak to that.
Okay, Jackie or Mark, would either of you have a comment on that?
Jackie had to step off. Sorry, it's Susan again. What I can tell you is we will provide as much information through the supply chain as possible. We will ask organizations to work with their own health and safety departments and IPAC resources. And we recognize that the use of disinfectant in any other form other than in a wipe, like a cavi wipe or whatever you're used to, is not ideal. But unfortunately, it is the position we are in when there is a constraint on the physical product. As Jackie had explained at the beginning, the fabric for the wipe is what is constrained, not just in Canada, not just in Ontario, but across the world. So moving to an alternate product we recognize is not ideal in some situations. We'll provide whatever we can, but the product will be an appropriate level product. Right now, wipes that we provide are hydrogen peroxide based wipes. We will have spec sheets available for any organization that wishes to get the spec sheets regarding that regarding the product that's provided. And to be honest, that product hasn't hit our warehouse yet in the central region, but you may start to be seeing it in other parts of the province as well. Sorry, go ahead.
That's great. Thank you very much. Question about surgical masks. Are they safe to use even if they've expired? And at what point are they no longer safe to use? I think Devin looks like she's ready to answer.
Yeah, so not ideal to use expired PPE, obviously, but there may be some provisions during critical shortages, but you'd have to, verify that they're still looking like they're in good shape. It's really not ideal though, so obviously be working to ensure you've got an adequate supply. They could be used for things like training, so you don't necessarily have to get rid of them. So yeah, I'm not sure if my colleagues have anything to add to that.
No, that sounds good, Devin. Just making sure they're inspected before every use, every time one is used.
Okay, thank you. Someone is asking for additional clarification on the use of spray over wipes. Is there a public or health directive that you can share that would speak to providing that clarification?
It's addressed in the Provincial Infectious Disease Advisory Committee Best Practice Document on Environmental Cleaning. So that is sort of where that's coming from, just saying not to use the trigger sprays for the reasons Casey had mentioned earlier. I'm not sure if there's anything else as far as the directive goes, though.
Okay, thank you, Devin. Someone is asking, why does Dr. Fauci recommend 2 masks? Can you help us understand that?
So the current official recommendation from the CDC, I think, is to just wear 1 mask. I think they do have some studies in the works looking at 2 versus 1. And I'm not sure if he was referring to medical masks or non-medical masks. As far as medical masks go, we have talked about the 3 layers already and how they're regulated for use with claims that they are effective to wear for PPE. And just thinking about the instructions for use of medical masks, they don't direct the user to wear more than 1, so wearing 2 may actually conflict with the instructions for use. And a mask over something like an N95, again, not following the instructions for use. N95s aren't fit tested with a second mask over top. Potentially it could interfere with the seal and the ability to perform a seal check. And if he was talking about the non-medical masks, again, I don't think there's any evidence that this is more effective. The recommendation to wear 1 currently is because of the risk associated with wearing 2. So ideally you're wearing 1 that is properly fitted.
Okay, thank you very much, Devin. Does forceful coughing cause aerosolizing of virus?
So current evidence indicates that forcible coughing does not cause aerosolizations. And aerosolizations, when I say that, I mean really tiny little particles that float through the air and suspend in the air for long periods of time. So forcible coughing causes more droplets. And your medical mask and your eye protection are protective against that.
Okay, thank you, Casey. Someone is asking if there's any direction on patients masking, and they've gotten into a specific incident debriefing where they've learned that some percentage, a high percentage of patients are choosing not to put on a mask when the service provider is in the home. So do you know if there is any provincial direction on patients masking?
So, I mean, there's some specific guidance around the use of masks for source control in public buildings and things like that. The ministry guidance does address things like in home care, indicating the client should wear a non-medical mask unless they have screened positive for COVID-19 and care can't be delayed. Then you would give them a medical mask to wear, and just some provisions of who shouldn't wear a mask. But other than that, like, is it specifically a question, do you think, about sort of getting compliance from patients who aren't willing to wear one?
Yes, I think it's what's the right of a capable person to make this choice for themselves and the impact on the service provider who's in their home and questions like that. So perhaps that could be one that is followed up with an answer in the Q&A document as well.
Yeah, because it would come down to sort of, policies and sort of, information that could be provided to the patient around being compliant with those requirements.
Okay, very good. I think we're getting close to our time, so I think I'll close it off there. And thank you both very much, Kevin and Casey, for your answers. And we'll take away, I know the PPE team will be taking away all the other questions and answers that came in and providing a full list of answers to those questions we weren't able to get to during this call today. Thank you very much. I'll turn it back over to Kristen.
Thank you so much, Kathleen, and thanks again to Devin and Casey. So before we close out the session for today, as mentioned before, your feedback is really important to us. So we're hoping that you'll indulge us in a few minutes and complete a post-session evaluation poll. We're about to launch the poll, but in addition to that, if you have any other comments on what you liked about today's session, what potentially we could do better at with future sessions, or also topics